Hello everyone. So in this video we are going to talk about hip dislocation. We have three types of hip dislocation: the posterior, the anterior, and the central hip dislocation. The posterior hip dislocation is the most common, reason being anteriorly the hip is supported by iliofemoral, a strong ligament. Posterior hip dislocation not only is most common, but 50% of time it is associated with fracture dislocation. That is, the posterior rim of acetabulum is also fractured along with the hip dislocation. Mechanism of injury in the case of posterior hip dislocation is a dashboard injury. As you are able to visualize in this image, the knee booster has hit on the knee, leading to posterior dislocation of hip, and that is what is a dashboard injury. But dashboard injury actually has four components. Let's watch over this image. The knee booster, when hits on the knee, it can lead to patellar fracture. The posterior cruciate ligament may be stretched, so it may lead to PCL tear. The femur shaft may be fractured, along with which there can be posterior dislocation of hip. So actually dashboard injury can have four components. Not only this, you should also remember a car accident or RTA not only leads to dashboard injury, there can be footboard injury, a steering wheel injury to the chest, and a head injury due to windshield, as you are able to visualize in this image. Talking into the diagnosis of patient with posterior hip dislocation, so the patient will have history of severe trauma that will be followed by a pain and swelling in the region of hip, and there will be classical deformity which can be remembered by mnemonic father, that is flexion, adduction, and internal rotation at the level of hip joint. Watch in this image, the patient has flexion, adduction, and internal rotation, and side by side we have a photo of a patient with anterior dislocation, where we are able to see contrasting characters, that is flexion is the same and patient has abduction and external rotation in the limb. One more difference that we are able to see, the patient with posterior dislocation has relative shortening of the limb, and patient with anterior dislocation has relative lengthening of the limb. Also, on examination of a patient with anterior dislocation, you see patient has the head of femur can be felt in the region of gluteal region, whereas a patient of anterior dislocation, the head of femur will be felt or palpable in the region of groin. Also, most of the patient with posterior dislocation are going to present with these classical symptoms or presentation, but sometimes a patient with femur fracture may be missed for posterior dislocation. So a patient presenting with femur fracture of shaft we should take a X-ray of pelvis
So
too.
in X-ray of patient with posterior dislocation, we classically see that head of femur is outside of acetabulum. That is the first finding. The second finding is the Shenton's line on the side of dislocation will be disrupted. And the third thing is due to internal rotation of the femur, the lesser trochanter is less visible. You should compare it with the normal side too.
So treatment of such a patient is emergency, because the head of femur is prone for AVN, and to prevent this condition we need to go for treatment as soon as possible. Manipulation is done under general anesthesia because muscle may be under spasm. So closed reduction is done. We have three techniques: Ellis, Stimson, or Baltimore. Remember, if you reduce the dislocation, the bony chip fracture will fall off on its place by itself if it is small. So don't worry about it. Worry about the dislocation itself. So in Ellis technique, as you are watching in this image, one of the assistant will hold the pelvis, and the doctor will itself apply the axial force along the direction of femur, and a popper click sound will be heard that will signify that the dislocation is means the joint has relocated, and it is reduced, and then traction can be applied for some time. This was about the treatment given as closed reduction. So now we will understand when in which condition open reduction is needed. So a patient where closed reduction is failing, or if there is an intra-articular fragment that is preventing the closed reduction, in that cases we will go for open reduction. Also, if there is a nerve injury that is of high grade, not a neuropraxia, and we need to go for nerve exploration, in that case too we have to go for open reduction. Complication of such a case can be discussed with anterior and central dislocation because the complications are more or less same in these three. So we already discussed about anterior dislocation presentation, that is flexion, abduction and external rotation, relative landing, and head is palpable in groin. The mechanism of injury and anterior dislocation is forcible abduction and external rotation. Think of a child that is in the tree and is falling off, and the leg is stuck in the branch. So in that case, the leg may undergo abduction and can undergo external rotation. That may be one reason for anterior dislocation, which is very rare. Talking about central, you also are able to see x-ray of anterior dislocation in this image. The lesser trochanter is very much prominent in this case, and Shenton's line is disrupted again, and head of femur is out of the acetabular fossa. In central dislocation, what we are able to see is that the head of femur is driven through the medial wall of the acetabulum into the pelvic cavity. Now this head of femur to different extent can be inside the pelvic cavity. It can be completely inside or only somewhat. That depends on the degree of the trauma. Now, aim in central hip dislocation is to achieve congruence of the articular surface as much as possible, to make the range of motion or make the joint in the previous state as much as possible. So for that, after achieving to achieve the congruence or the articular surface, skeletal traction is applied distally and laterally to the leg. Okay, and if there is reasonable congruence and reconstitution that is achieved, we are going to continue the traction for 8 to 12 weeks. But if we are not satisfied with the congruence or the reconstitution and fragments are not pulling back, we are going to go for surgical reconstruction of the acetabular surface in that case. So this was somewhat about the hip dislocation. Let's talk about and this is a x-ray first for central dislocation again. Now let's talk about the complications in that case. We can have sciatic nerve injury, as the nerve is located just behind the hip joint. The sciatic nerve is prone to injury, but generally this sciatic nerve injury is a neuropraxia, and after relocation of the reduction of the dislocation, this is going to be improving on its own. Okay, it is a transient phenomena, but in cases there is a open fracture along with the hip dislocation, nerve exploration may be required. AVN of femur head is very common if delayed reduction of hip joint is done. In that case, we are able to see that AVN of femur head may be visible on the X-ray as increased density after 1 to 2 years, when completely the femur head is means it is completely from inside it is empty, and in that case it is of no use now, and then we will be needing prosthesis. Other complication may include vascular sign of Neurath, and we can have osteoarthritis, myositis ossificans. So this was briefly about hip dislocation. Hope you liked it. Thanks for watching.